Hi, I am Zainal Abidin Samak from the University of Bristol. This is joint work with Phil Clatworthy and Mirmehdi. In this presentation, I will briefly present our work on the prediction of thrombectomy functional outcomes using multimodal data. Let me start with the clinical background and motivation for this study. Stroke is an interruption of blood flow in the brain region. It is the second most common cause of death worldwide and fourth in the UK. Mainly there are two types of strokes. One is hemorrhagic, which occurs when blood vessels burst, and the other is ischemic stroke, which occurs when there is a blockage in the blood flow. The majority of stroke cases are ischemic, about 80%. In this work, we focused on ischemic stroke treatment, more specifically endovascular thrombectomy treatment. In thrombectomy treatment, a catheter is inserted into cerebral arteries to break up or remove the blockage. Recent randomized clinical trials have shown that patients with ischemic stroke benefit from endovascular thrombectomy. However, selecting patients who are the most favorable for the treatment remains a challenge. Therefore, estimating the potential success of the thrombectomy treatment outcome would reduce the risk and support the clinical decision system to improve the quality of stroke care. Our main goal in this study is to estimate the suitability of a patient for thrombectomy treatment from baseline NCCT scan and clinical information. Before going into details, I would like to briefly present related works in the outcome prediction of stroke treatment. The majority of the works in this area have used only clinical metadata information to predict treatment outcome, mainly applying machine learning algorithms like logistic regression, support vector machine, random forest, and superlearner. There are a few works that have applied deep learning on only imaging information. For example, Meyer et al. Used MRI scans from the ISLES challenge to predict stroke treatment outcome. And recently, Hilbert et al. Utilized a maximum intensity projection of 3D CTA to predict thrombectomy treatment outcome by using a ResNet model. Similarly, there is a handful of studies that apply CNN on multimodal data to predict stroke treatment outcome. One of these works, the one closest to our work, is Becci et al., who used a shallow CNN model with 2 convolutional and 2 FC layers to predict binary outcomes of thrombolysis treatment using a dataset of 204 patients with NCCT volumes and related clinical data. While their dataset is similar and a deep learning method is used, there are major differences in our work. For example, they focus on thrombolysis treatment, whereas our focus is on thrombectomy treatment. Also, they only predict binary outcome of treatment, but in our work, we predict binary outcome and individual levels of treatment outcome as well. In this study, we used the Mr. Clean trial dataset that was collected by Fransen et al. In the Netherlands. It consists of imaging and clinical data of 500 patients from 16 medical centers. Imaging data includes baseline NCCT and CTA volumes, as well as 24-hour and 1-week follow-up scans. In the clinical metadata, there are patient demographics, medical history, stroke score, and imaging biomarkers as well. To measure the functional independence, in other words, successful rate of treatment at 90 days, the modified ranking scale score has been used. So this score would be the label information for our experiments. This is the baseline NCCT scan when the patient was admitted to hospital, and 24-hour follow-up, and finally 1-week follow-up scan. As can be seen, in the baseline scan, brain damage due to stroke can be hardly detected with untrained eyes. In the 24-hour follow-up scan, it can be spotted when looking at the symmetry in the brain, while it is very obvious in the 1-week follow-up scan. This clearly shows how challenging it is to predict the 90 days outcome from the baseline scan alone. It is important to note that from the set of scans, we utilize only the baseline NCCT volume in this study. In our proposed method, we consider multimodal data, both raw baseline, NCCT scan and clinical information. Generally, MRS scores are divided into 2 groups, and the model will predict a binary outcome. We estimate not only binary MRS scores, but also individual MRS scores. To the best of our knowledge, there is no other work that can predict individual MRS scores. In our proposed network, we designed a shallow but robust network architecture. We used spatial and channel attention modules, which are based on squeeze and excitation attention. It encourages the network to capture discriminatory features both spatially and channel-wise. We also explored a pre-trained network called MedicalNet, trained on different medical images such as brain, heart, and lung scans. And finally, we applied focal loss for class imbalance in the dataset, as the distribution of the MRS scores are highly imbalanced. For instance, the number of patients with the MRS score 0 outcome is 7, while the ones with MRS score 4 is 133 patients. In our proposed network architecture, there are 2 main modules, image encoding module and fusion module. Our image encoding module takes a 3D NCCT volume and processes it by several convolution blocks, where each convolution block consists of 3D convolution layer, instance node, leaky ReLU, and strided convolution layer in the first 2 blocks for downsampling. Next, convolution features are fed into 2 attention modules, channel squeeze and excitation and spatial squeeze and excitation, which help the network to focus on more discriminatory features both spatially and channel-wise. Later, attention module features and convolution features are aggregated and global average pooling is applied to generate 1D image feature vector before passing into the fusion module. Later, 1D image feature representation and metadata feature vectors go into image and metadata fusion module. In the fusion module, imaging and metadata features are processed by a fully connected layer followed by a ReLU, and then concatenated for the final classification layer, where softmax is applied to the output of the final FC layer for final prediction. It is important to note that since our dataset consists of patients, whether they received thrombectomy treatment or not, and we need to encode this information in our training process. Therefore, when we train our model with only NCCT volume and NCCT volume with clinical metadata, we use treatment information in our network. When an experiment is only on imaging, MI is a one-hot vector of treatment information only. Otherwise, MI is clinical metadata, which also includes treatment information. We present 2 main experiments. In the first experiment, we divided MRS scores into 2 groups, good outcome, which is MRS scores between 0 and 2, and bad outcome, which is MRS scores between 3 and 6. Therefore, the model will predict only binary outcome of treatment. As can be seen, when training was based on 3D NCCT volumes only, our proposed model performed best, with the 75% accuracy, 0.46 F1 score and 0.67 area under curve, while other networks performed significantly worse in F1 score and area under curve. Our simple clinic deep neural network that used only clinical metadata performed better than the model using NCCT volumes. However, This can be caused by the rich information in clinical metadata. This means it includes radiological biomarkers which were determined by expert radiologists from 3D and CT scans. We obtained the best performance in these experiments when we combined imaging and clinical information, with area under curve jumping from 0.67 to 0.75, and F1 score from 0.46 to 0.62. In this second experiment, we predict each MRS score individually. Additionally, we use one nearest accuracy metric as an evaluation metric in this experiment. The reason we use this metric, since the ground truth labels may not be precisely accurate, given clinicians' judgments, and also the ground truth labels are ordinal, so estimating one nearest classes could be considered as a reasonable prediction. Our proposed method performed best in both comparison metrics compared to other methods. Similar to first experiment, the performance of many of the models benefited from combining imaging and clinical metadata information. However, our proposed model's performance decreased in the one nearest accuracy measure when using multimodal data. Since for individual MRS score classification, the predictions were spread across classes instead of accumulating around the majority ones. With the ablation study, we demonstrate the importance of the attention modules, channel squeeze and excitation, and spatial squeeze and excitation. When they are excluded from our proposed method, it can be seen that there is considerable performance loss when not using attention modules. For example, in dichotomized experiments, F1 score is increased by 0.05 in both imaging and imaging with metadata information. Likewise, in individual MRS experiments, the performance increased by 5 and 6% in accuracy metric. Overall, the attention modules increased performance by about 5%. Finally, here there are some qualitative results. Label orders for each image are as follows. First value, number on the left, is ground truth MRS score. Second one is predicted binary MRS score, and last one is predicted individual MRS scores. Green color represents correct prediction and red color shows incorrect prediction. As it can be seen in some failure cases, although the predicted MRS score is incorrect, the prediction is one class near the ground truth, which we classified as correct for our nearest accuracy metric. To sum up, we proposed a novel approach to estimate the outcome of thrombectomy by using multimodal data. Using imaging information and clinical metadata increased the performance of the model. Also, attention models help to improve the performance by encouraging the network to capture more discriminatory features. And in this specific task, a well-designed shallow network could outperform deeper networks like ResNet, which is the most common architecture for natural image tasks. In our future work, we want to collect more data, especially from minority classes, to tackle class imbalance. We would like to explore metric learning and adaptive fusion methods as well. Finally, we want to make use of temporal changes of the stroke over time by follow-up scans. Thank you for your attention.